Hi, Dr. कैसे हो भाई? So, perfect. So, we are starting with our live surgery webinar on nose block surgery. So, nose block surgery is very, very important because nose block is the reason why people develop obstructive sleep apnea in the later part. So, without wasting time, let me come to the first patient. Age क्या है Sweb? Now, if you can you focus on this? Yes. Now see, can you see this CT scan of the first patient? He is 36-year-old.
Yes, sir.
He is 36-year-old. Now look at the CT scan. He complains with recurrent cold, sardi, khansi, nose block, everything. So symptoms are all the same for every patient, almost. Somebody will have this more, somebody will have that more. But this patient also has got a good amount of postnasal drip, right? So that's because of the inferior turbinate. Now if you look at the CT scan, if you just try to look into the nasal cavity, here the septum is straight. So the cartilage is almost straight, but as you go behind, look at the septal deviation. It's completely deviated on the right side. What is the cause of deviation of this patient on the right side? A concha bullosa on the left and turbinate hypertrophy on the left side. That has turbinate hypertrophy is a result and concha bullosa is the cause. This concha bullosa has pushed the septum to the other side. Now look here. What is the difference in the size of the inferior turbinate? Almost 6, 7, 8 times. So unless you do a good amount of turbinoplasty concha bullosa excision, this patient will not have an open nose. Now what are the chances that once we perform this surgery, he will require a surgery again? If you do a good amount of septoplasty, turbinoplasty and concha bullosa, he has no disease in the ethmoids. Can you see here? Focus here. Focus here. See, he has no disease in the ethmoids. Because he has no disease in the ethmoids, the chances are very, very less that he'll require a surgery again. So with this understanding that this patient has majorly a structural problem, highway divider is crooked, there is a stone here, there is a stone here. So once we take care of his anatomical issue, his problem will be solved. Now what he still may have, he will not have ethmoiditis for all the foreseeable time because he didn't have it for 37 years. Chances are very less that he'll have ethmoiditis again. So he'll not require a sinus surgery again, but he may still require a nasal spray because he may have seasonal allergic rhinitis or some irritant rhinitis. For that he might require a spray or some antihistamine once in a while. But his major problem of blockage, sneezing, watering, everything will go away. Now give me 2 minutes. I will just wash up. The patient is already induced, so I'll just start the surgery in a few moments.
Good morning, sir.
Good morning, good morning.
Just give us 1 or 2 minutes, sir. We are almost ready.
Yes.
क्या ये कनेक्टेड है? एंडोस्कोपिक पिक्चर प्लीज.
Picture.
Start the endoscopic picture please.
Endoscopic picture. Sir, can you see the endoscopic picture? Hello.
Patty.
We are very well, you can see, yes. Very nice.
Patty. Now see my microphone please. मेरा microphone शुरू करो.
Setting change.
Dr. Rajesh Valand has joined.
Yes, good morning.
Hi Rajesh.
Dr. Rao.
Hi Rajesh. I just explained the CT scan. So this is a 36-year-old gentleman with symptoms of nose block, watering, sneezing, and the standard symptoms that all these patients, all the nose patients have. So he has got a gross DNS on the right side. Patty, please. You can see Dr. Patel has cut the vibrissa so that the endoscope fogging is little less. I'm just packing the nose with the patties. Now this packing is very important. I'm using 4 ampoules of adrenaline in 30 ml. 4 ampoules adrenaline in 30 ml, so that there is a very good amount of decongestion. That is the most important step, and never try to save time in that. So surgery is basic, but to understand and execute it nicely, this patient has symptoms of obstructive sleep apnea which are not developed too much, because his palate is little longish, but he is not choking at this point of time. So we have done a sleep study and sleep endoscopy. We are not concentrating on that, and we have only advised that this nose surgery should help him great bit, and he may not require a palatal surgery once we do his nose. Can you see the large concha bullosa, Rajesh? Rajesh, are you there? Once I start operating, I will not be able to talk. I will only be able to, once I start operating, there will be no two-way communication. It will be only one way. So you take care of people who are asking questions. If they have any question, please answer it. Otherwise, most of the questions I will be answering later on. Sister, can you give me the local, please? Okay, now I am starting to operate. So I am starting with concha bullosa excision on the left side. You can see the huge inferior turbinate. I will keep on demonstrating every step and keep on telling everything, but there will be no two-way communication from now onwards. Alright, so yeah. So now I am injecting the concha bullosa. We will be demonstrating all technologies as needed. We have piezoelectric ready, we have micro debrider ready, we have coblation Eris wand, halo wand, everything is ready. Knife, please. So unfortunately we have to mute all the participants so that there is no two-way communication, and I will be answering all the questions in the end. In between, if Dr. Rajesh has anything, Dr. Rajesh can add. Now I have insides this mucosa on the middle turbinate, more on the medial aspect. Now the bone is pretty thick, so what I will do is I will use the piezoelectric. Piezo is just getting ready. I am waiting for the piezo to get ready. The bone is very thick, so I am not finding my blade going easily inside. So this is the piezoelectric. With the piezoelectric, I am making the bone incision. Alright, you can see I have entered. Audiovisual, can you mute unnecessarily the sounds which can disturb me? Keep everybody on mute. They can put their questions in the chat box and Dr. Rajesh Walan can answer that. Right now I am showing the use of piezoelectric to dissolve the bone. This middle turbinate is very, very bulky, and there is some air inside, so obviously I will be able to use the scissors. But to conclusively reach that, can you see that? I have opened the concha bullosa with the piezoelectric. The thickness of the bone was quite a bit. I have been able to dissolve that bone, and now I can use the scissors. Alright, upward please. Debrider ready. Now I am taking the micro debrider foot switch please. What is important is to go pretty high, remove this upper part of the concha bullosa, because it will keep on otherwise obstructing the frontal recess area. Alright, so this is a standard concha bullosa excision. There is nothing great about it. Suction. So we have 4 cases today. This one is the simplest. A virgin septoplasty, turbinoplasty sister released this. Then we have, I think, a revision case. We have large septal perforation case. All adult septoplasties and turbinoplasties I have kept today because we have done enough number of workshops on tonsil adenoid. Now I am injecting the septum starting from the posterior point. So this is the part where the septum is most deviated on the right. So I am going in from the left. I, as a fact, always prefer to go in from the left because it's my habit. But you can go from the right if you want. In certain cases, there is no rule on that. So I am injecting from posterior to anterior, because if you start from anterior to posterior, there will be little bit of bleeding. You can very well do that as well. Now this is the most important step, because if you do not have a perfect plane to start with, now this is the skin. If you do not have a perfect plane to start with, your surgery will always be compromised. Now see the nasal valve, how badly it is blocked on the right side. So I'll have to do a SMR, not a septoplasty. Therefore I have called it surgery for nose block. Whether you do septoplasty, SMR doesn't matter. You need to open up the nose. The patient needs to breathe. I have no more space to inject, and anyway the injection is over. So now I'll take the incision. So I'm just waiting for a minute because I have just injected. The nurse is holding the endoscope. Now this incision is the most important thing. If your surgery, can I get my glasses? Now see, this is the skin, this is the mucosa. If you take the incision on the mucosa, it will bleed. So always be on the skin, just where the skin is joining the mucosa, always be there. All right. Take your time here, because if you are not deep enough, you will not get into the correct plane. Sister, can you suck? And if you cut the cartilage, then again you will struggle. Now let me see if I have reached the correct plane. So once you reach the correct plane, things will be much easier. No, this is not the correct plane. I am trying to get the correct plane. Okay, can you see? That's the correct plane. So you should feel the grating. Once you have got it, now I will hold the camera in my hand and ask the nurse, knife please. So this is still not the best plane. As I was telling earlier, one has to be very, very careful at this point of time. If you are not in the correct plane, just wait for the correct plane to come. The correct plane is not this one, it's here. Can you see this thin layer? You have to get into this. Sorry, there will be no two-way communication, please. That's not allowed by National Medical Organization or whatever, NMC. So now see, getting into the correct plane, there is a deviated septum on the right side. So I have to preserve everything on the left. So I have to elevate the flap right till the bottom. All right. Now rest of the work is very easy. I have already elevated the flap right till the bottom. All right, give me a patty. So I'll put a patty so that there is no there is no bleeding and there is no problem with the view later on. I'll just put a small patty and wait for 20-30 seconds for the bleeding to completely stop so that you get a very, very good picture. Now see, I was telling that the plane was not correct. So this is not the correct plane. This is the correct plane. That small layer we have to differentiate right from the beginning. Now, where do I take my incision? As you know that this septum is grossly crooked here. So I need to remove things from here. If I remove from here, it will not make sense. So what are my landmarks? So I'll tilt the septum with the knife. Can I just increase this incision a little more? Pull it. All right. So now you see, this is the anterior inferior nasal spine. How do you identify? When you push the septum to the right, you can see that the posterior part is moving to the left. This I call a swivel sign. This is moving like a swivel door. The axis of the swivel is here. So this is the attachment of the anterior inferior nasal spine, which is my landmark where the septum is attached anteriorly. So I need to preserve this point. Now I'll take out this patty because bleeding has stopped. Knife. So this is my anterior inferior nasal spine. I will just preserve the anterior part of the anterior nasal spine and take my incision so anteriorly. Can you see how much I am only leaving this attachment half because I have to come quite anterior. This is the mistake most people do. I am doing a perfect SMR. I am not doing a septoplasty. And see, I am only preserving 5-6 millimeter of this strip, anterior strip. I am not preserving too much, or maybe 8 millimeter, at the most 1 centimeter. So see this, I have to take away this part. This is the part which is crooked on the right. If I do not take away this part, this patient's nose will never open up. You will always have the blocked feeling, and if you have a failed surgery, next time you will be very, very cautious in advising any patient a surgery, and you will try to give them just a nasal spray, which is a gross disservice. Now on the superior part, I am preserving 3 to 4 millimeters only. Can you see that? Only 3 to 4 millimeter or 5 millimeter, not more than that. See, this is the part which is most crooked, this one. My job is to remove the blockage on the right side. I am going in from the left. So I will make sure, see the part is getting crooked here. I have to come maybe a little 1 or 2 millimeter more in front here, somewhere here. That's my limit. Now I'll try to get into the perfect plane and go to the right side. All right. So if I do not go in the perfect plane, then again I'll mess up on the right side. So I'll take my time. All right, see, getting into the perfect plane is the most important thing. All right, so that's the perfect plane. And as I said, I'll take this 1 or 2 millimeter strip out. Audiovisual, can you please keep everybody mute because I am not supposed to get disturbed during live surgery. I am supposed to concentrate fully on the patient's health. That's the correct plane on the right side. So no bleeding. And on the right side, the flap is bound to tear. So I'll not try to preserve the tear on the right side. I have already preserved everything on the left, right? Because there is a spur, it's bound to tear. I will not care about that at all. Now, give me the knife. As I said, 1 or 2 millimeters strip which was extra. Let me remove that anyways. And all right, once I do that and I separate it, okay, now you will appreciate that this cartilage is now not abutting, it's overriding the anterior one. That means this was the extra length. All right, so extra length was causing the septum to get deviated on the right side. And once I do this, now let us see how it is behaving on the right side. Have I got it out? Not completely. All right, let me see. Right now it's completely crooked on the right. So let me first remove it and then we'll reassess. Lux, please. Once I remove the cartilage, periosteum elevator. Now see, this cartilage is sitting into the, see, that's the reason my anterior part has not become straight, because it is still being pressed by the posterior part. So I need to take away this posterior part right till the, can you give me a knife please? It's not fully separate. All right. So once I separate it, then I can see if my anterior segment is becoming straight or not, and what further I need to make it separate. So I have, now see this, knife please. Still there is a little lower part which is pending. So in spite of removal of this, now this much was extra, this 2 or 3 millimeter was extra. Even if I remove this lowermost end, still it is not becoming completely straight. So what I'll need to do is I'll have to take off a small strip even more. But I have to make it straight, otherwise there is no point performing this surgery. Now I'll remove the lower part. All right. Lux, please. Let me remove all this cartilage now. So going up, can you see? This was the cut I had taken. I am only leaving behind 5 millimeter at the top. That is more than good enough, but I'll tell you the point how you prevent a deformity. Knife please. Let me just take away this thing which we had decided to remove. Lux please. Can you make this patient's head a little high? Just a little head high. Now see, the lower part was deviated to the right. The absolute higher part is deviated to the left. Fine, perfect. Now see, this part is still crooked to the left. I do not want it to leave it like that. So I am going still higher. But First I'll see where I am. So in the next case possibly I'll show it to you on navigation. Septoplasty using navigation. Maybe in the next case I'll show it to you. Now see, this is the bone. Can you see this? This is the bone. This is the cartilage. This is the bony cartilaginous junction. So if you do not disrupt the bony cartilaginous junction, this cartilage will not collapse. If this cartilage does not collapse, even 2-3 millimeter, 4 millimeter of the cartilage is enough to maintain the shape of the nose. Now I have removed lower part, I have removed higher part. Now let me see what is the effect on the deviation on the right side. Can you see it's completely straight now? Right? It's totally straight. It was fully blocked. You're saying something? Swave, you're saying something? Now I will take away the lower part, I will take away this part. So I am relatively satisfied with now let me remove the maxillary crest. So we have the piezo to remove the maxillary crest. We can very well use that. But it's a very big maxillary crest. It will take some time, and the posterior part of the maxillary crest does not have any vessel. That's the cartilage, that's the maxillary crest. And as I said earlier, the left side mucosa is perfectly normal. So I'll concentrate on removal rather than on preserving the mucosa. Can you give me the lux forceps? So let me remove the posterior part of the vomer and that's the perpendicular plate of the ethmoid. So can you give me a scissor? I'll show you traditional means first, then I'll show you the high. So if you want to still go higher, now this thick part of the bone is always below the frontal sinus. Look into any CT scan, this is not below the skull base, this is below the frontal bone. So you can very well just cut it with a scissor and take it out. You will never ever hit the skull base. So see how high I have gone. Your skull base will be here. Let me show you. So in the next case possibly I'll use the navigation to show you where the skull base is. Skull base will be high up there, right, where the thin bone, that's the perpendicular plate of the ethmoid, that's where the skull base will be, high up here. So now the posterior end, this is the lower part. You can see the maxillary crest is pretty wide here, but there is no vessel at the back. The vessel is right here where I am touching. So I will not, as I said, I will not concentrate on the flap on the right side, because I have saved the flap on the left. I will first remove the posterior part of the maxillary crest, which as I said has no bone, no vessel, so there will be no bleeding from there. And I will reach the rostrum of the sphenoid now. I will remove the rostrum of the sphenoid. Give me a suction please. I will show it to you nicely. Block. That's the spur, and you can see I have made a tear in the right side of the flap without any mercy. That's not needed. Once your left side is normal, the other side you do not have to waste time to save the flap. So I have removed now the posterior part of the maxillary crest. Let me see if there is anything more. Sister, can you clean this and give it to me? Can somebody else also wear gloves to help? All right. Now I'll use the piezo to reduce the maxillary crest where the bleeder comes. The bleeder comes here. So I'll use the piezo. So that there is no bleeding and still the blockage is gone, and I will only trim it. There is no need to fully remove the maxillary crest because it's not obstructing. So if there is any part which is obstructing, I'll only take care of that part. Now let's see from the right side. Can you see this septum? There's still a little bit of septum high up there. I'll just take care of that in a moment. This flap was touching on the right. There is still a little bit of maxillary crest. I will remove it. Can you give me lux, please? So once you do a surgery, do it completely. Don't do it half-hearted. Don't leave anything for the next surgeon. Alright, so this is the maxillary crest. Can you give me a good suction, please? This is not working. Curved suction. Give me a curved suction. Alright, so my septoplasty work is almost complete except that very small part high up here. Alright, so first I showed you the scissors. Now I'll show you the piezoelectric. So the part which is very high, this part, I am taking down with the piezo. So without breaking, without any chance of hitting the skull base, if you really think so, because I am anyway pretty ahead of the skull base. This is not the area of the skull base. This is the area just below the frontal. So I am just taking down this. With the piezo. Alright, can you saw that? Now whatever is the cartilage is there, I'll simply cut it off. Now let's see what is the situation here. Can you give me a patty, sister? So concha bullosa on the left is done. Septoplasty is over. I'll just put a patty and then show it to you. The right side was the culprit, the blocked side. Let us see what our surgery has produced till now. One more patty, please. I'll just put a patty for a moment. Now let me see if I am able to see the roof of the nose or not. If I am not able to see the roof of the nose, then my surgery is still incomplete. Alright. So see, there is no cartilage here, there is no cartilage here, there is no cartilage here. This is absolutely straight. I am only leaving cartilage here. There is nothing here till here. Completely straightened. There is no need for rhinoplasty. You could very well do it with a closed SMR. Now see, the septum is absolutely straight now on the right side. Alright. Now I am able to see the roof of the nose here. See, this is the last bit of bone, this one. So this is the middle turbinate. So obviously the skull base will start here. I am here. This part is not even this skull base. I'll just show it to you. Alright, so this part is still below the frontal. Can you give me the scissors? I'll just show you the traditional instrument so that everybody can do it. Now this part which I showed you was ahead of the middle turbinate, was below the frontal sinus. So I have gone that high, removed everything without bothering about the skull bed. This is below the frontal. This is not below the cribriform plate. So I can very well pull it. Right? This is the message. And in the next case or whatever, second, third case, whatever, we'll show it to you on navigation also. So high septoplasty is very important because now look at this. Now you are seeing the roof of the nose absolutely completely. I have reached here, right? Now his olfaction will be absolutely open. So left middle turbinate taken care of, septum taken care of. Now I'll take care of the right middle turbinate. So you can see the right middle turbinate is lateralized, this one, all right. So the air passage is fine, but the sinus drainage is little compromised. So what you can do, you have to make sure that you do not fracture it up there. So you fracture it here. Now see this, the posterior end where it is attaching to the bulla, just go inside and make a nick. So you get a lot of space here. All right. Now still if this part is paradoxically curved, give me the scissor. So what you can do is you can make 2 or 3 cuts. That's called 3-cut technique. I had presented it in 2009 at Maharashtra State Conference. You can make 2 or 3 cuts and just leave it there. And you'll see, just keep it there and put some gel foam and it will heal in the new position. So it will create a lot of ventilation on the middle meatus on the right side. Now most important is the inferior turbinate. Since I am on the right side, all right, there is still a little bit of bone which I am not happy with. Give me a lux forceps. Just a little bit of bone. I remove that. Now I am absolutely happy. Now we'll go for the turbinoplasty. So I am going to show today all kind of turbinoplasty is possible, but let me start with the most simple one which everybody can do, the microdebrider assisted turbinoplasty. So we have all the tools ready. Give me a patty please. Now see this. This right middle turbinate is, any inferior turbinate is anyway not that big because the septum was abutting here. But still, if you do the turbinoplasty only on the left side, then the patient will start complaining of blockage on the right. So what I am doing right now, I am starting from the posterior. Sister Patty ready? All right. So I have not injected the inferior turbinate. So there is bound to be a few drops of blood. But see, this posterior part is absolutely polypoidal. It's like a polyp. So the moment you remove this polyp, see there is no bone here. The bone is only in the superior part. The inferior part is completely polypoidal. So I have come right from the posterior end to the anterior end, removing the lower border, preserving at least 70% of the medial mucosa. All right, this is the simplest tool anybody can use. And now I have not yet injected, I am just saying again, and try to get the perfect plane with a periosteum elevator. It's easier said than done. And therefore we have tools like piezoelectric to melt the bone, but I am preserving 70% of the medial mucosa of the inferior turbinate so that the patient does not develop any crusting or empty nose syndrome. All right. Now I have got into the plane reasonably well, not absolutely fine. So obviously, because it's a cold instrument, you will see some blood, but your end result will still be the same. Now what I'm doing, I'm out fracturing this inferior turbinate bone, and taking a curved scissor, large curved scissor, I'm cutting away that bone along with the suction piece. Keep a halo wand ready. All right, can you see this bone is out? Give me the scissor. I'll keep everything ready, but I'll first use the basic instruments before jumping on to the higher ones. Now this, can you see I have preserved a little bit of bone over there. That bone, the posterior end, that contains the artery and the nerve supply. Give me the, I'll just show you. You must be thinking that I have removed a lot. If I just put that turbinate back, see how much of the turbinate is. It's like a normal turbinate, right? But the blockage is gone because you have taken off the major bulk. Now this is a piece of bone which, if you want, you can just leave it, because see, the airflow happens like this, right? So simplest with basic instrument what you could have done and still get a very, very good result is what I just showed you now. Just touch the lower part. I am not even using coblation right now, I am using cautery. The other side I'll show you coblation. So very, very gentle, so that it does not bleed in your post-op period. Now even if you leave it like this, your patient will have an open nose for life. Now still there is a little bit of bone here, but I'm okay because this side is not much need, and this much of space you can see is right. So there is no cartilage, no bone here. This patient will have an open airway. Now on the left side, this turbinate is really huge because the DNS was on the right. Okay. So now see, there is no space here, and this turbinate is definitely going to be quite a bit of bleeding. So what I can do here, I can take the coblation wand. So I am taking coblation wand, go on to setting of 9. This coblation wand, that's set on erase. I asked for this one. You're not ready. I asked, no, I want, acha, okay, erase is ready, so I'll demonstrate erase. Okay, no problem. No, this is not ready, it's showing 5. Okay, go on to 7, high plus. Acha, that, fine, you're on high plus, take. All right, fine. So now I'm using the halo wand of coblation to perform a relatively bloodless turbinoplasty on the left side, which is otherwise is going to bleed like crazy because it's pretty large turbinate. What I'm going to do, I'm going to start again from the posterior end. That's the posterior end. I am eating away the posterior end just like we did with the micro debrider. Now see, once you do this, this will never come back in life. And since you are not using coblation, the healing time will be much lesser. It will heal in 1 week, 10 days time, rather than the 1.5 months it takes with the cautery. And now I am doing the same work which I did with the micro debrider on the left side. See, I am preserving the upper part of the mucosa, 70% at least I am preserving, and the lower part I am taking away with the halo wand of coblation, Smith and Nephew. All right. Now I have got a very, very clean boundary. Suction please, suction cautery. So all right, the bone is pretty hard. I'm just sucking away the blood which was collected from septoplasty. Now what I'll do is, this is the mucosal incision. Now I'll take the bony incision with the piezoelectric. Sister, can you release this? Now I'm taking my bony incision below the mucosa, as much of bone. I have taken a full thickness bony incision on the inferior turbinate. Full thickness, going right till the posterior part. And since it's the piezoelectric, I do not have to bother about the blood supply, nerve supply. It will not damage the blood supply and the nerve supply. And therefore, I can very well see that's where the bone is ending. So I've taken a full thickness incision on the bone while undermining the mucosa. All right, very clearly seen. Now give me a periosteum elevator. Right, see this lower part. See, it's completely separated. The bone is completely separated. Give me the scissors now. Now I'll just take a scissor and remove, because the bony incision is already done. I do not have to bother that I'll lose the turbinate. All right, so that's the lateral mucosa, and here I have just, can I see, straight forceps. See how much of inferior turbinate I have removed by a precise incision. Now still, that's the bone. That's where I'll get the blood supply and the inferior nerve supply of the inferior turbinate. Give me the microdebrider, please. So what I'm doing now will give this patient a great relief, because his post-nasal drip was mainly because of the inferior turbinate. See, I've not yet opened the blood supply and the nerve supply. There's still a little bit of bone. Give me the piezoelectric. So I will reduce this bone a little further, because this is the area of the blood supply and the nerve supply. So I'm not using debrider. I'm just removing that extra bit of bone, because if you leave behind bone, it will keep on creating granulations. If there's any bit of extra bit of bone which is seen, I'll remove that. All right, now there's no bone. Can I just use the cautery for a while? Only this very small, see, this is the area near the blood supply. So I'll not leave anything. All right, now give me the suction, please. Suck it, suck inside. Just suck. All right. Now see, you might be thinking that I have removed a lot. Now as I put it back, see how much is, almost the whole of the turbinate is still there. Now even if this patient goes and stays in Alaska, he cannot have crusting. Even if he's in Dubai, he will not have dryness, and naturally there will be never ever any problem of empty nose syndrome. Got it? So what happens is that we do half-hearted surgery. We do not do a complete surgery, and then we expect the patient to remain happy. How he will remain happy? And if your septoplasty, turbinoplasty does not give you adequate result, then you do not advise this to the next patient. Now this patient, once we have done so much, this surgery might save a palatoplasty on him at later stages in life, because now his pressure of breathing will decrease drastically. All right, so there's no bleeding. What I'm going to do now is to pack the nose. I'm definitely going to pack it, though there's no bleeding. Now see, there's still a little bit of natural, the curve. There's no cartilage, there's no bone, but this mucosa, which was ready to, always in this shape for the last 36 years, 37 years, will try to go back. However, you see this cartilage, I can still make it a little more straighter. Give me the knife, please. Can you hold this flap? So why this patient will not have any deformity, I'll explain you. Hold the flap. See, the attachment of this cartilage to the nasal bones is intact. The upper lateral cartilage is attached here. The lower part is here. This bone was a little longish, and if I want to still further make it straight, I can make partial cut. But now if I do too much, then I have a little risk. So I will not do too much. This will gradually straighten, because see, the memory is broken. Even if it is a little on the right, doesn't matter, but most of it will remain straight like this. It will be put in this position there. That's the reason I'll pack. Right? This memory, if I can break a little more, I'm not 100% happy, but I cannot remove any more of the cartilage. So I'll try to just break the memory here. I cannot now cut it through and through till the lower part, because that will, what I've done is I have cut it through in half, not the full. This will, so it will be still looking a little deviated, but obviously the upper part will completely open up, and this is also almost, chhod dijiye, leave it. See, it will almost remain like this, which is okay. So this is, if you want to do 100% straight job, you'll have to do open nanoplasty, which is obviously not needed. So this is 95% of the passage which is opened. Now I'll take some gel foam soaked into, as I said, there is still some tissue left on the right side. With the basic instrument you can do only that much, but with the advanced instruments I am not happy with this, so I will still remove the lower part. Can you see that? I will make sure that it does not bleed. If you do too much, then the artery will open up, because the artery is right here. When you remove this bone, I have not used piezo, I am just using the basic instruments. You do not leave behind any bone chips. So now I have debrided the bone chip, and I am cauterizing this area, because the bleeder, if at all opens, will give trouble. So little bit of cautery, only on the lower and the lateral aspect, nothing on the medial aspect. All right. Now gel foam, please. So I'll put gel foam first lateral to the middle turbinate on the right side. Did he have any sinus issue? Let's check out the scan. Sinuses are clear. So this may be just a secretion. I will not do anything to. What you can further do, just give me a sister. Give me a 135-degree curate. You have it. Now see what happens. I'll just tell you one more thing. When the middle turbinate with the high deviated septum, the middle turbinate being lateralized, the uncinate is also lateralized. Can you see? The uncinate is also blocking the middle meatus. So what I'm doing is, I'm just out fracturing the uncinate. You can very well do an uncinectomy, there is no problem. But he does not have a sinus problem. I have just out fractured the uncinate, that's it, without any mucosal damage, gel foam. So improving his ventilation of the sinuses. No mucosal trauma is the rule, because that will lead to least mucosal trauma. You cannot say no mucosal trauma. Least mucosal trauma. On the opposing surfaces, if you give trauma on the opposing surfaces, then obviously the patient will have developed synechia. So this is to keep the middle turbinate in position. Now higher part of the septum is not covered by any pack. So I am putting some gel foam. This part is between the nasal bones. See, the nasal bone is here. That's the nasal bone. So if you put gel foam on both the sides, it will be absolutely a good pressure packing. So you will not develop a hematoma in the upper part of the septum, which is the commonest area. And if you do not develop hematoma, you will not develop synechia. So your major problems of septoplasty will get solved only by using the basic, instruments, the basic stuff. The understanding is the most important. All right. Now I'll pack the left side. Concha bullosa has been done on the left side. Did we do the concha bullosa on the left? Yes. Yes. So I'll put some gel foam. So if you have a concha bullosa which is not filled with air, which is only filled with bone, you still do the same. So unfortunately in the world there is no surgery advised for a bone filled concha bullosa. Air filled concha bullosa is very, very well known. So because you do not have the tool to do it, so the surgery has not been designed. But with the piezoelectric you can do a very, very nice concha bullosa excision surgery, bony concha bullosa excision surgery. Can you see the bone middle turbinate is here. I have filled up. Now the upper part of the septum between the nasal bones is being filled with gel foam. Now this gel foam will keep the pressure and not let any septal hematoma form. Now you might say that after so much, will you pack the nose or not? Yes, I will. But what I'll use for the packing is rapid rhino. Rapid rhino has a facility to increase the pressure as much as we want. And is there any need to suture it? Absolutely not, because this will just be put back here. So I'll put a rapid rhino. Give me the rapid rhino. Rapid rhino is now, I'm putting the rapid rhino. Can you see that? So I'll put my camera, the scope on the flap, put the rapid rhino, and after putting the rapid rhino, I'll pull it little anterior again, so that it is sitting, the edges are completely approximated. Now I'll put the rapid rhino on the other side as well. So after putting the rapid rhino, I am inflating it with air, around 5 to 6 release 5 to 6 ml of air on each side, or maybe 8 ml of air just. So you can measure the pressure of this. Is the gauge ready? But right now I have put the pressure very high. Why? Because I want extubation. Now during extubation there could be some gel foam which have gone into the nasopharynx. So I'll take sister, give me a, show this. All right, sister, show this camera. So what I'm doing now, I'm sucking away the blood. I'll go into the nasopharynx. Now you see this patient has got a large soft palate. It's a good case for obstructive sleep apnea surgery, but with this nose itself he will possibly get relieved so much that we can save on a palatoplasty later, possibly. If not, we'll do it. One sec, let me just go behind. I'm trying to look for any gel foam. Can you see that was a big gel foam which has come? What this gel foam could have done during extubation, this could have come into the larynx. So do not leave behind any gel foam. Sorry. In the nasopharynx. That is a job to be done by us, not by the anesthetist. Once I am sure that there is no gel foam and clots. Alright, so now there is no gel foam. There is no gel foam at all. No clots, no bleeding. Now I am good for washing out. Alright. Alright, so the gauge is here. I'll show you the gauge. See, right now I put the pressure more than 120. You can't leave it like that. It will cause septal necrosis. So after, can you see? It's maximum pressure. So this is given more than 120 because the patient is going to have a blood pressure going up. Can we have the external camera now? इधर दिखा दो. All right. So now I am free to take questions. Rajesh, what are the questions people have asked, and people can actually unmute them and ask questions.
Hi Vikas, excellent surgery demonstration. I think we enjoyed it a lot. Basics were explained, that was more important. And we got a lot of questions.
Yeah.
I've tried to answer some, but I think you should answer some because so people were asking questions about can an anterior stitch be taken for this patient?
If you can just give me 5 minutes, Rajesh, you can just unmute yourself. You can put on your camera. You talk to people. I'll just go into my room and I'll go on my laptop so that it will take half an hour for this patient to get extubated and the next one to get intubated. So we'll keep talking from my room. Is that fine? My anesthetist says, Dr. Vanita, you know her well. She's just throwing me out of the theatre now. So this is a 41-year-old male. Again with nose block, recurrent cold, and because of that he has also got a perforation in the right ear. He was operated. Can you have the head high, please? ये कर दिया है क्या? All right. All right. I am showing the external camera can show actually the navigation. I am using navigation only to show you the landmarks. External camera, please. So see, Rajesh, are you able to see the navigation probe?
Yes.
External camera, please. So what I am going to do, keep picture in picture, please. It's too far. So it's too far. Let me see if it is working. It's fine. Are you able to see what I'm doing? Picture in picture?
Yes. Absolutely.
Are you able to see the screen? No, screen has to be bigger.
Yeah.
Picture in picture alternate. Change it.
The endoscopic picture has to be smaller.
Correct. Are you able to see, Rajesh, now?
Yeah, the endoscopic picture went away.
All right. So you saw what I was doing. Are you able to see the screen?
The screen is seen very small. Now the screen is big, but the PIP is not there.
Leave it. No problem. So what I'm only doing, Can you see what I'm doing on the screen? I'm just taking away all the points. All right.
Yeah, yeah, yeah.
Now we'll see. I'll stop here and see the. I'll wait for the accuracy. Now it is calculating the accuracy. Can you see it has become all green? Accuracy is 1.3 millimeter. All right. So which is good enough. So now I am going. Continue showing the screen. Can you see that? This is actual.
Yeah.
Now I'll go to navigation. Chali, go to navigation.
Can you show the external picture bigger?
ये लगाइए इसके ऊपर.
And show again the external camera. Can you show it bigger? Yeah. And now can you do that again?
I'll do that.
See how it was.
I'll do that. I'll do that. Just. Shanti, Shanti. All right. So now I am taking one instrument. Sister, बीच में से. Can you see? Now see, this instrument is on the nasal tip.
Right.
PIP, endoscopic picture, PIP please. All right. Are you able to see inside, Rajesh?
Yeah. Endoscopic picture not seeing, but external camera is seeing very well.
Audiovisual endoscopic PIP. Endoscopic PIP. No, I need the other way round, Rajesh. Audiovisual, I need it the other way round. ठीक है, चलो, if they cannot do it, then I can't help. See, you can see where the tip of the instrument is. Okay, let me start this surgery. I'll not waste time on this. But wherever I am doing now, so suppose this is the septum. Are you able to see where the septum is? External camera, can you? Suhaib, what is the problem? No, but that one has to be big, na, Raj. Suhaib, that has to be big, na. Yes. Idea. Yes. The external camera has to be large, correct. Now the external camera, that's fine, that's fine. The external camera, can you concentrate on the cornel? Suhaib. But external camera, concentrate on the cornel. Chalo, theek, I will not waste time. Patty, please. Suhaib. Patty. No, but you need to understand what we concentrate on. No? Zoom in.
But he's not able to do that.
Zoom नहीं कर पा रहा है.
He's talking to his senior.
तुमको उसको zoom
He told me.
PIP का नहीं बताया था.
Now I'll ask him to keep this big. Once navigation बताएंगे तब बड़ा करेंगे.
ठीक है, जो चलो जो भी बात है जाने दो. ठीक है, now let's concentrate on the surgery. So I will show you on navigation, Rajesh, wherever once I start operating, I will obviously not be talking to you bilateral. ठीक है सिस्टर, आप थोड़ा सा ठीक, all right. Okay, can you again see the deviated septum, Rajesh?
Yeah.
High DNS, same case, similar case. So we have a revision septum after this, we have septal perforation after this. So those who will be interested in the higher stuff. But what I want to show you is that people do not do the high deviated septum thinking of that they are near the skull base. They are not. So this is what I want to show. One sec. All right. So can you see that this deviated septum, Rajesh, are you able to see this?
Both pictures are going parallel now. This and that.
So now see, I am very high here, but I am below the nasal bone. I am not below the frontal sinus also. He cannot zoom in, Rajesh. Suhaib. Zooming in with this camera is not a problem, na? One sec. Let him zoom in. Just zoom. No, but I need half and half वाले में zoom.
Then he's saying only one will go.
क्या कुछ भी ठीक है. Now see, here I am below the nasal bone. Rajesh.
Yes, I am here because
हाँ, this is cartilage. This is below the nasal bone, not even below the frontal sinus. Here, this high, you are still below the frontal sinus. All right.
yes.
So you till you are at the level of the middle turbinate, it is all frontal sinus. Can you see that?
Right.
Now, when you go behind the frontal sinus, behind the middle turbinate, then you are below the skull base. Till this point, you are not below the skull. This is the only point I wanted to show. So, all this bone is below the frontal, and what is that frontal beak? So, can you ever damage the frontal beak? No. So, the thick bone on the CT scan is below the frontal beak. It's only the thin bone which is below this almost halfway of the middle turbinate is your cribriform plate. Is it very clear? Now my job of navigation is over. So I will remove all this without even fearing about the skull base. Any questions on this? Patty. Local.
I think a lot of people's confusions are gone.
Yeah.
After seeing that,
Yeah.
what you see in the East Coast is now competing with the thinking, so they will not be scared to do that one.
Correct. So this is somebody is talking. Can you make them mute, please? I cannot hear. So now I am starting to operate. So everybody will go on mute. Audio visual, make everybody mute, please. I am starting to operate now. Earlier I was not operating. Now I am operating. So please keep everybody on mute, including Dr. Rajesh, because then the guidelines will maybe not adhered to. All right. So now for everybody, as I showed earlier, that the deviated part, the thick bone is always below the nasal bone or the frontal sinus. So now there is no need for PIP. You can go into full mode. I have injected. I will start the septoplasty again. So 2 cases of simple septoplasty, virgin, and then 2 cases of revision. Those who are interested can stay back for the revision. Beginners, obviously revision becomes a little too much. Again, I took the incision in the skin and not in the mucosa. At the junction of the skin and the mucosa, mucocutaneous junction, just ahead of that. Now I am going to elevate the flap. Getting into the correct plane is the most important step, as I said earlier. Taking full length of incision is also very important. If you do not take full length of incision, alright, so this is the correct plane. If you are in the correct plane, there will be no bleeding. In this case, the DNS is on the right, so left side I will preserve all the flap properly. Alright, there is a small spur on the left here that I will take care of. So I have elevated the flap. That's the nasal floor. Can you see? Completely till the nasal floor. And now I'll take my again swivel sign. Let me first increase the incision right till the top. If you have not done that, you will not be able to see the upper part. Again, swivel, press it on the right, you will see the septum, the posterior part going to the left. Swivel sign again, universal. So that's the attachment. If I preserve, see, that's the attachment. So I am preserving the attachment half, 50% of the attachment I am preserving. And coming ahead, removing the cartilage, leaving behind 3 to 4 millimeter at the top. Again, getting the correct plane on the right side is again very, very important, because if you do not get the correct plane, there will be bleeding, you will not get the, will take a lot of time. See, this is the deviated septum on the higher part. And that's the spur. Fine, the flap could be preserved on both sides, why not? So the question will be that in this case you did not need to remove so much of cartilage, so why are we removing so much of cartilage? Question is that why should we not remove it? We should do the best job, maximum surgery, not minimum surgery. If there is no complication of doing the maximum surgery, then do the maximum surgery so that the patient doesn't get the maximum relief. Okay, now can you see that this part is longer than here? This is almost 1.5 millimeter of extra cartilage. That's why the cartilage becomes crooked. It's always extra. So if you have to remove that extra cartilage, you have to dissect and remove it. You cannot make it straight and try to fit it into this same place. Now that's the bone which has come. So let me I will ask the audiovisual to go on to combined mode again. Just give me a moment. Let me do all this lower work. I'll tell you. Suhaib, I'll tell you. I'll tell you when to go on to 50-50. So all this lower part I am removing. Once I am going higher, then I'll ask you to go 50-50 so that you can show the navigation. Alright, so let me now go higher. I need this suction, sister. Navigation suction. Yes. Now put external and this 50-50. Alright. Hold the flap from a distance. Alright. Can you, yes, that's perfectly zoom. Can you see this bone? Now this large piece of hard bone is below the frontal sinus. This is what I wanted to demonstrate earlier. This bone with a bone marrow is below the frontal sinus, and only when you go behind this thin bone, that is below the skull base, that's below the cribriform. So this bone, even if you do not have the piezoelectric, you can still remove with the scissors. So I'll ask for a scissors. Without any problem, you can cut this bone with the scissors. Very hard bone. Very hard bone. Now see, this is the attachment of the bone and the cartilage. So unless you remove this bone, the high deviated septum in this case will not work. But this part is below the frontal sinus, so without any fear. Now what has happened is, when I pulled this thin part, that is the part which is below the cribriform plate. So you have to be careful not to damage higher than this. See, this is below the frontal, so therefore I had no problem. But when I go here, then now I am below the cribriform here. Can you see that? So that far is the cribriform. Cribriform is not here, it is starting here. Till here it is frontal sinus. Now it is cribriform. Alright, now he is putting the camera in a different position. I need you to show. Give me the piezo till that time. So give me the piezo. Foot switch. Alright, so till the time he is setting up his camera. Are you on? VIP. Till the time they are adjusting the camera angles, I am just completing my work. Now see, I have removed almost completely the bone. I will show you. Sister. Brother, tell me when you are ready. Just concentrate on the first. Zoom in, zoom in. सुहेब बताओ ना. This is fine. Now see this. I am still below the frontal beak, right? This is frontal sinus. The cribriform will come after this. Here, cribriform is here, not here. So this is what I wanted to stress. And if this thing is understood, people will not leave behind. And whatever extra cartilage is there, I am still removing that extra cartilage. Now let me again show you. So which place is this? When I put it and see it on the navigation, see, this is the thing I removed. Can you see this? Now it has become straight. Here till here it is frontal. Till here it is frontal. Till you see the middle turbinate is only frontal. Only when you go halfway through the middle turbinate, then you will get the right. So the middle turbinate attachment is here. That's the skull base. So here this is no. So high deviated septum has to be taken care of. And now we can switch off the navigation. My work is done. Now external camera can be removed. We come back to our old work of I need to remove this. Navigation can be removed, can be switched off. It's no more needed. All right. Now you can straight sit. Now let me remove this lower part of the maxillary crest without bothering about the mucosa on the right side, because I have already preserved the mucosa on the left. Suction. Okay, there is still some spur here. Very hard bones, so a lot of bleeding. It will all stop once you complete the surgery. So he came to me for a revision tympanoplasty. I have operated many patients in his people in his family. So around 6-7 years back he had got a tympanoplasty done, more than that. But he got a recurrent perforation. The job was done perfectly the first time. Now see this. See, because I did not use the piezo, there is a little bit of bleeding. So क्या दे रहे हैं sister? What will you give me? What have you got? Suction cautery. All right. So I'll just, because here I did not want to waste time, I just took out that big maxillary crest. So only thing is that keep a debrider ready. Now see this bleeding. All right. So be very, very specific. Only cauterize the vessel. Do not cauterize the whole bone. Debrider, please. So I can see some debrider suction not ready. Okay, it's working. I'm just removing that small thing. Can you give me some straight forceps or something? All right, that's it. So my septoplasty is over. Now the bleeding has almost gone away. Let us see if there is any more part of the septum. That's the rostrum of the sphenoid. It's completely straight, so no problem. There is a small spur here. Can you give me a lux forceps? This spur. So if you use piezo, it will obviously not bleed. If you use lux, it is bound to bleed, which is okay, doesn't matter. Lux. Just show me if there is any. So naturally, when you remove all those bones, there is bound to be a little bit of bleeding, which will be taken care of by the nasal pack. Now see, there is no damage to the mucosa anywhere. All right, on both the sides. Middle turbinate is normal. We are not supposed to do anything. Inferior turbinate, huge. Huge. So again, क्या रखा है? So if the cobulation is ready, I again start from the posterior end. Completely ablating the posterior end, which is polypoidal. Completely ablating the inferior part, which is polypoidal, 30%. Come right till the anterior end. Clean it. All right. Now we'll take the piezo, make a very clean cut. That's the bone. See, the bone is ending here. So I'm starting my cut into the bone. Very clean cut into the bone. Lower 30% of the turbinate being sacrificed. Alright. Here the bone is very, very thick. I am going inside and cutting the bone. I think the soft tissue was not completely cobulated. No worries. So there is a little bit. Give me the debrider, please. Now the part which is already delineated, not working, suction of micro debrider suction, please. Connect. All right. No, it's blocked. Just give me a moment. Micro debrider suction was actually blocked. They are just changing it. So you saw that I did not do anything. I do not do any injection to the inferior turbinate because it's very vascular. If you inject adrenaline, then the chances of the adrenaline getting absorbed is very high. Now if you see, the bone is already delineated. Whatever area is to be removed is already decided. Scissor, please. So this area should have been cobulated. I've just debrided it. Scissor, please. Now this bone was already divided, you saw. Soft tissue at the posterior part I am dividing now. So I have not gone through the vessel. I have not gone through the. I have another way. If you want to preserve the mucosa completely, we have another wand called Eris wand. Alright. चलिए अभी right now I need the halo wand. Halo लगा है ना अभी. So right now the halo wand is on. So I will, whatever I debrided, I will still use the halo wand for hemostasis. So not much of cautery being utilized. Cautery will create little more crusting. Cobulation will cause lesser crusting. Healing will be faster. Apart from that, whether you do cautery or cobulation, the results will be, final results will be the same. Alright, so see, there is still a little bit of bone, very little amount of bone, which I am not interested in removing completely. Now as I outfracture this, see, in spite of removing so much of the turbinate, what you see here, the medial mucosa is now, it looks like a normal turbinate, but without any obstruction, without any secretions, suction. Which side concha bullosa?
Inside lamellarization.
All right. So he has got lamellar concha bullosa, more lamellar pneumatization, correct? So I'll take care of that also. I'll not leave it. Give me a. And again for this, piezo is the best alternative. Now see, you can see the whole of the inferior turbinate preserved, right? There is no problem at all. In spite of me removing so much of the inferior turbinate, you can see the whole inferior turbinate preserved. So that's where you can give result in blockage, nose blockage surgery without any problems of empty nose syndrome or crusting, even in cold areas. And see, I have not done anything to this mucosa. This mucosa is normal. So even if the patient, whatever mucosa is there, it will keep on functioning normally. Typically when you do channeling of the turbinates, you damage the mucosa, the functional mucosa. I have not damaged the functional mucosa. The serous mucosa I have not damaged at all. Now, see this cartilage, this middle turbinate has lamellar pneumatization and is definitely a little bigger. So what I am doing is, I am gently cutting away the bone, melting the bone. Now give me the micro debrider, please. So very precise. As much as I wanted to remove, I can remove. And whatever I wanted to preserve, I can preserve. There is still a little bit of bone which I wanted to take away. No, sonopet not working. Check what is the problem. No, sonopet not working. Just see what is wrong. Sister, attachment check करिए क्या हुआ है. All right, see there is still a little bit of bone that I wanted to remove. My sonopet is not working at this point of time. They will have to refix it. चालू हुआ क्या? All right.
Just check the sound.
Let me know. Anyway, my job is done. My job is done. Okay, now the sonopet is ready, but my job is done.
We also have on the left.
I will use it again on the left side. All right. All right. So now maximum work without any local, please. Again, left side, you can see the middle turbinate being very large. So whatever maximum space you can create without causing any disability or complication, knife. See, I cannot get in with the knife because the bone is very thick. It's not possible. So if I use the sonopet, yes, now it's working. Thank you. Is the power less? All right. So the piezoelectric actually melts the bone without damaging the soft tissue near it. Very thick bone, but I am just melting away that thick bone. Fine. See, I have got into the perfect plane. Perfect. Debrider. No, hold on. Let me first assess the turbinate on the. See how thick was the bone inside. Little bit of this bone still requires sonopet. Alright, see the bone is completely melt. Debrider please. That extra thickness of bone I still want to remove with this sonopet. That extra, right? All right. All right. All right. I do not want to leave unnecessarily lot of bone chips. Alright, so now this middle turbinate is, give me the sonopet, just a little bit more of bone which I want to melt away. Divider please. See, every millimeter of space in the nose counts. Alright, so this is the perfect size that I wanted to see. Suction cautery. Now that this bone is raw, I'll simply touch it with this suction cautery so that it unnecessarily does not cause any bleeding in the post-operative period after pack removal. So there is a vessel here, so I have not gone. See, if you do too much of cauterization on the bone, it will heal in a very, very long time. That's fine. Only in this area that soft tissue. If you want to, you can cut and remove this part also, but then you will open up the blood vessel. It's not needed. Alright, now let me come to the inferior turbinate. So now let me use the same wand first and then I'll use the Eris wand. So the posterior part I'll be using the halo wand. Because posterior part is like a flesh, like a polyp. The inferior part, as I said, is like a polyp. Now if I want to take care of the sinusoidal part, this is the polypoidal part. And I want to preserve the mucosa completely. Suppose if I am not using sonopet, what I can use, now change the wand. Give me a suction please. We'll change to the Eris wand. Eris wand is the turbinate wand, but it's mainly for the soft tissue. The sinusoidal part will be acted best by the Eris wand. Give me a moment. So now you see this part is pretty fleshy. In the earlier cases, I used I removed the bone. Here I'll remove the flesh with the Eris wand. So the Eris wand looks like this. Let me just show you the wand. It's like a freehers. Can you see this? And there's a tip here. So it will go inside, it will melt the soft tissue like this on the bone. So I'll go inside from here. I'll go along the soft tissue. But for that, let me first out fracture this turbinate so that it becomes straight. Then I'll be able to go till the posterior part. Eris is ready? Alright. Now I am starting with the Eris wand at a setting of high. So I am first making my entry, and with the entry itself I am going to reach the bone. Alright, this is like a okay. And what I am doing now, I am removing the sinusoids. I have removed the sinusoids. And I'll try to go, sorry, it has come out from here. It went a little high. So I have to make my channel towards the bone. I am reaching right till the posterior part. Can you see that? I have removed the sinusoids from inside. Can you give me a suction? So most of the mucosa is saved, but from inside the sinusoids are gone. Lower part I have done with the halo wand. I have removed this, but obviously these are all demonstration. I still want to remove give me the piezo. I still want to remove that extra piece of bone, because that will give me the long lasting result. See, I can feel the bone here. Alright, so I'll start from the bone. Make a bony cut, lower 30%. Okay. See, this bone is very precise cut. This bone is cut, nothing here. All those bone chips I will straighten, and this is all soft tissue only. Give me the microdebrider now. So now, throughout life, blockage because of the nose will be taken care of. Lateral mucosa I am completely debriding. The bone which had already that's a small bone chip. Give me a straight forceps. Let me see, if needed I'll just pull it away. Now, there is no bone chip hanging here, there is only soft tissue. And in spite of doing so much, when I out fracture this inferior turbinate, you will see that there is absolutely no chance left for, I need some suction cord. Gel foam ready, pack ready. So the procedure is complete. I'll just show you the final thing. Gel foam please. So I have not done too much of cauterization here. Why? Because then it will take longer time to heal. This area is pretty high. My pack will come here. See, the inferior turbinate is completely preserved. Lot of mucosa, 70% of the mucosa is preserved. And I have gone inside and removed the sinusoids also extra on the left side. Alright, so my surgery is over. Rajesh, now you can take questions. I can take questions. Sure. So many times people do posterior neurectomy for allergic rhinitis. I am not a great fan of the procedure. However, in next case maybe we can demonstrate. Yeah. Yeah, Rajesh, any questions?
So people are asking radio frequency versus micro debrider, long-term result, which is better?
So see, if you do a good micro debrider, you will do the micro debrider only for the soft tissue, right? You are asking for this part or this part? Radio frequency is done for the sinusoidal part. I am using micro debrider for the, no, so that's what I am saying. I cannot answer the general question, Rajesh. See, radio frequency is done for the, yes, madam, go ahead. Yes, madam, ask question. Okay.
Exactly, the question needs to be framed exactly what you are asking for which tissue.
Correct.
Exactly, but otherwise the function of each is different. Radio frequency has a different function altogether, microdebrider has a different function altogether.
Correct.
So what tissue is it used?
Correct.
Radio
So
frequency can cut and ablate soft tissues, all of the inferior turbinate, the middle turbinate.
correct.
Very well. Regarding the bone, it may or may not, depending on the thickness of the bone. So, very thin bone, it can ablate or cut. Thicker bone, it may not be able to ablate or cut. But rest of the tissues all can be very well handled with radio frequency. I have personally not seen any crusting following radio frequency following 1 week, 6 weeks, 3 weeks, whatsoever. But some people may have complained of some amount of crusting following usage of radio frequency. Radio frequency can be used for hypertrophic inferior turbinates to ablate them at 3 points with different powers, and it can also be used to cut the tissue and then work on the turbinoplasty after cutting it with the radio frequency needle, as and when how you want to device the turbinoplasty. For middle turbinate also, contrabulosa, it can be used. One thing, it can be used just as how we use a knife handle, just use the radio frequency in that manner and then open it up and then break open the bone. Or if there's another procedure I have tried myself also, you can just ablate it first with a radio frequency bipolar forceps, which is like a cord. So the tissue completely shrinks and then it is very easy to collapse the contrabulosa. Far more easier. So that is also another mode of using RF for these two structures. Also, sorry, but we have used a little bit of RF also on the septum.
Very nice.
I have tried it on six cases as such till now. I didn't have access to endoscopic camera at that point in time. But I can say that if you have a minor deviation, how do you judge what is minor, moderate or severe? But minor is just about something which is just abutting the septum itself only. Minor deviation in the septum, you can use bipolar fork-like radio frequency probe, insert it into the deviation without any fear and use it up to a power of 1 to 3. Power of 1 to 2.5. That's the power which is there on the radio frequency machine. And after 6 weeks, you will notice the decrease in the curvature. It can become completely straight or flattened. This is very much dependent on judgment and experience. And because excess doing can result in a septal perforation, as all know, septum can, if you're doing too much branching, the mucosa can get denuded and it can result in a septal perforation. But otherwise, if you use anything up to 2.5, one power is very safe, but up to 2.5 on the septum can give decent results in a minor radio frequency or septal correction, minor deviation, very, very minor deviation. More than that, it could be. You can also elevate the flap with a radio frequency needle, but very carefully.
So I'll go down. Yeah, I'll बाहर ले लेते हैं इसको, बाहर ले लो, इधर से बात करेंगे मेरा. हाँ कर लो ना चेक. All right, so we'll come out. Yeah, so as I said, as soon as the procedure is over, I'm thrown out of the OT by Dr. Vanita. So we'll take questions now because my surgery is over. You would let me know what all people want to ask. They are really interested in seeing revision septums, which will be more messy. It is not going to be as clean. So do people want to see revision septum, or they are okay? I mean, I have explained everything. I have a revision septum and I have a large septal perforation.
People would really like to see a revision as well as a septal.
Okay.
These cases would be okay, everybody is doing them. But
Yeah.
how to deal with septal perforation? Because in your life, once or twice you will get septal perforation, and if you don't know how to deal with it, I think this will be an issue.
Yeah.
There is no.
Yeah.
Because I'm sorry, can I take your leave because I'm starting my OPD?
Yes, Rajesh. Thank you very much for joining, Rajesh. And in fact, it will take around 45 minutes for the turnaround time also. So by the time I'll keep everything ready, it will be 1 o'clock. So if there are any questions from the audience, I'll take them now. And then I'll take leave for an hour. We'll come back at 1 when the next patient will be induced and ready.
Thank you, Vikas. Thank you, audience. Thank you very much.
Anybody has any more questions to ask as of now?
Everybody wants to see septal perforation.
So, no, we'll join back at 1 with the revision because he's, I think, a 18-20-year-old boy whose adenoid I had already done. No, I think somewhere else it was done. So, we'll have to check. But it's a revision septum, that's I was told. I do not know whether it was operated by me. I would have done a half-hearted work because the child was very young, 5-6-year-old. I'll have to really check. But it's a good revision septum in an 18-20-year-old boy. So pediatric septoplasties, you have to do the good work so that the child does not land up with another surgery at the age of 18-20. That's what my message is. Even if I had done the half-hearted work 10-15 years back, it was not correct. So if anybody has any more questions?
I think people can unmute them and they ask questions. So I'll take a leave.
Yes, thank you, Rajesh. Thank you. So if there are no more questions, then we'll take your leave. We'll join back at 1 o'clock with the revision septum. Thank you.
साल हो गया ना, अभी 23 at age of 10.
बैंड बजने वाली है मेरी.
पार्टी रखना दी अच्छे से ज़्यादा
देखो टर्बनेट्स का क्या हाल है.
अच्छे से
टर्बनेट सही है, बड़ा ही है.
निकाला
ये क्या है? सेप्टम.
बीच में निकाला हुआ है।
हाँ,
रख लेना बॉन्ड में सब निकाल रख लेना। हाँ चालू करो
कुठला लावून आला
हॅलो वन लावून द्या बरं.
हॅलो
चालू करू नंतर चेंज करू वाटलं कॉटरी काढून घेऊ प्रतीक्षा पुढचे केस इन्सुलेटेड कॉटरी विथ पॉईंट
अभी नहीं, नेक्स्ट केस के लिए.
नेक्स्ट केससाठी चालू नहीं हुआ एरर है लागलेला नाही वाटत पिन नाही लागलेली
क्या लिखा है?
ब्लॅक पिन नाही वरची
वरती पण लावले खाली
हाँ.
पण लावले ना त्यामुळे
साइनस में कुछ नहीं है ना इसको?
नाही सर
हे बघ हे खाली
किया था.
आता बघ.
अच्छा, चलो. हेड हाई हो गया ना?
किया है
ठीक है, ओके. चलो 1 बज गया, चालू करिए.
जा रहा है लाइव जा रहा है
15 नंबर बोल.
All right, so welcome back again. So this is the third case. He is 23-year-old boy. At the age of 12-13, he was operated for adenoids. You can see the scar of the adenoid. I had done this surgery, and we have done minimal septoplasty, minimal turbinate reduction at that point of time. You can see very conservative septoplasty was performed by me because the child was young, and 12-13 years back we did not used to do a complete surgery for in pediatric age group. So now he has developed septal deviation. His nose was totally blocked on the right side. So it's my own revision which I am doing after 12 to 13 years. And see, I had done a little bit of turbinoplasty because septoplasty was not aggressive, so I have done a little bit of turbinoplasty on the right side here. So he was managing. But now you can see the high deviated septum, which I am going to correct today. And we have done his sinus. There is nothing in the sinus. So this part of the septum was done properly, but this high deviated septum was left.
סוגרים, אומרים עליהם, בסדר. זה עובד ב-90% מהמקרים. אבל 10% המסכנים נשארים בלי ספוס והקום.
Audiovisual, can you mute? Can you mute everybody? Audiovisual. I will be explaining. This is a revision septoplasty. Now I am operating, so that I will not take any questions, and so you can keep everybody mute. Now, since it is a revision septoplasty, the plane is going to be little difficult. So now this part of the septum, the higher part of the septum was not removed by me earlier. So I am going to use that part, because if there is any cartilage left, I can at least get some plane over the cartilage. Can you get the table up, please? The whole table up. No, that's, yeah, table up, table up. Yeah, thank you. Head high, little bit head high. That's it. Thank you. All right, sister will show. That's the caudal border of the septum. Taking the incision, little cut. As I said, it's going to be difficult to get the correct plane. It's more than 12-13 years of the previous surgery. But once operated, the plane becomes difficult. Fine. Now I'll take the, give me a patty also. Flap on. शांति से मिस्टर, शांति से, एकदम कोई हड़बड़ी नहीं है, शांति से, फट जाएगा। थोड़ा और अच्छे से अंदर से पकड़िए। Naturally, as we expected, in a revision there is bound to be bleeding, and we cannot hurry up. We just have to keep our patience and wait. We still have to be in the correct plane. And I do not want to use any cautery, any burning. I do not want to cause any trauma. Just wait for 5-10 minutes. And as I said, minimal septoplasty was performed. So obviously there is cartilage. If there is cartilage and it's already 12-13 years of this surgery, so we'll get some plane for sure. At least we have got some plane till here. Now, so that was a septoplasty performed. It's not a SMR done. Now see, that's where the cartilage has been removed from behind. So here I am unlikely to get a proper plane behind this point. Now let me see if I really need to so wherever the cartilage is removed, anyway the septum is straight. I need not go there, right? Otherwise I'll create perforation. If I try to go in that area, I'll create perforation. I need to go high, and higher septum, as I said earlier, generally would have been not done. So here getting a plane is very difficult now. So this cartilage is removed from here. So this is the part which has not been completely done. I'll put a patty again, let it I'll just wait for a couple of minutes again for the bleeding to completely stop. Nice. So few weeks back rather, in the Venta group, World ENT Surgeons group, I had posted a video of pediatric septoplasty, and the comment was that I was very aggressive. So that aggression has come from doing my own revisions. This is my own revision. So in this case I had done what was considered a conservative septoplasty, and the result is that I am doing the same case again. Same surgery again after 10-12 years. Nobody likes to get the same job done again. And nobody likes to do the same job again and again. Now, the anatomy is distorted. However, we know that he has got mainly a high deviated septum here. This is the part which needs to come out. Let me see if I can get a little more space on the top. All right. So, leaving behind 2 to 3 millimeters at the top. Leaving behind 4 to 5 millimeter in the front. And going down till the right, this is the attachment. Can you remove your instrument? Thank you. So unless I remove this attachment, the caudal part would never become straight. That's the higher deviation. So the bleeding in this case is less than what we expected, being a revision. Give me the patty now. I'll put a patty again. Suction. Knife. All right, so that's the lower part of the cartilage. It's difficult to get a complete nice plane. I'll have to create a plane because it's all fibrosed. All right. Now, sister. That's the higher part. So I've gone pretty high, leave it. Now see this, higher deviation is completely gone. This septum has become completely straight now. Now this middle turbinate was also compressed to the right, and there is a lot of glue, lot of discharge here. Let me see. On the CT scan he did not have sinusitis. That's the large maxillary ostium, accessory ostium. The uncinate is intact. Accessory ostium is there. I am just creating a space for the middle turbinate to remain lateral, medial. There is no need to do anything more. Middle meatus is open now. Now let's look at the turbinate. The right side, the turbinoplasty seems adequate. However, I will possibly debride a little bit of the posterior end. Debrider suction, please. Not much actually. No, suction of debrider. Micro debrider suction, please. Actually, there is not really too much on the right side. However, this should be the final surgery on this patient. Is it ready? I'm only removing the extra polypoidal thing. That's it. I'm not really doing too much. So it's already adequate suction cautery. Very, very gentle touch. Very, very gentle. There is nothing much to be done anyways. Very little. Out fracturing of the inferior turbinate. Just creation of a little more space by out fracturing, that's it. Sonopet ready again. Alright, so here there is a little bone. I'll use the sonopet to melt that bone and create a little more space here. See the use of sonopet. I could remove that extra bone and create some more space without hampering the function of the turbinate. Alright, the function is perfectly normal. Now let's look on the left side suction. Alright, clean it. Now left side definitely needs some treatment. right, in the regular way, because nothing has been done on the left side. So I'll take the micro debrider, because that will be the most effective. Only a little bit of channeling seems to have been done before. Very large bone. Then I'll take a piezo. You can give me a suction cautery first. I'll just use the suction cautery. I'm showing you the regular ways that you can achieve great results with the basic instruments. Only thing is that if you use cautery, your healing time will be a little more, but the net result will be not different at all. Now you see, huge amount of bone. So I'll take the piezo. Starts from here. I'm going at the back. Very, very large bone. Using the piezo, to make the bony cut. Through and through bony cut. Now see, this whole thing is straight forceps. This whole bone is divided. All right. After this, we'll take a micro debrider and remove this whole extra lateral mucosa. Give me the micro debrider, please. Just one moment. Trying not to open up the blood supply and the nerve supply. I've already divided the bone with the piezo. There's still a little bit of bone here. Piezo, please. I'll use the piezo to melt the bone. Straight forceps. Debrider. All right, so that's more than enough. Straight. Let me see if there's any bone chip Anywhere? No, that's a soft tissue. Give me a small cautery, please. So I'll just take a little bit of suction cautery to gently touch on the cut edges. I can use coblation also, doesn't matter. Alright, so see, this is the bone, not completely removed. That's the soft tissue, very gently touched, and not leave this bone chip. Alright, healing will be faster if I remove the bone chip. Very, very gentle. Now it seems that we have removed a lot of turbinate, but you'll see the moment I out fracture this inferior turbinate, you'll see how much of the inferior turbinate was still preserved. 70% of the mucosa is still preserved, right? Alright, so that's about a revision septoplasty and turbinoplasty in a 23-year-old boy. Some around 12-13 years back we have done the adenoidectomy. I'll show you the adenoid, which obviously has not recurred at all because a complete job was done for the adenoid, but we have not done a complete job on the septum and on the turbinate because the child was younger, and therefore we have landed up with a revision surgery. Let me just remove this blood clot. Can you give me a good... So I'll show you the adenoid area. Can you see that? That's the adenoid wound, scar, no adenoid tissue regrowth in 13 years. Alright. Wherever you do a complete work, like now here we are doing a complete work in the turbinates, so this will not have to be revised in all foreseeable future. Alright, and we have protected, saved sufficient mucosa. Gel foam, please. So no complications by and large, no septal perforation. Even in revision septoplasty we could preserve the flaps on both the sides. And so we'll call it a day because the next patient of septal perforation has not got a proper anesthesia fitness. There is some BP issue. We might have to postpone that case. I would have loved to show that surgery as well, but we'll have to call it a day because we do not want to take any chance on account of increased blood pressure. We'll just see how it goes. If it is fit, we'll do it, but we are not going to keep you waiting to show it live. So thank you very much. I am just coming out in a moment, and anybody who has a question, I'll be very, very happy to answer that. And we believe that every ENT surgeon should do good work for in the early stages itself for nose block. बंद कर देना. एक्सटर्नल कैमरा बाहर ले लेते हैं. So anybody who has a question, any suggestions? I cannot hear anything, brother. All right. क्या डाला है चैट में? Okay, so somebody has asked the question. हाँ, अब इधर से ले लो. Cold saline infiltration. Oh, there are so many. All right, I'll try to answer all those questions. Anterior stitch can be taken, straightening can be done. Sometimes give cut on the concave part also helps. That's correct. Did you find an artery in the posterior part of the turbinate and cauterized? Many a times we had done it earlier. Now we try to avoid it. What to do if cold instruments are not available for turbinoplasty? Can we do with turbinoplasty scissors? Yes, you can very well do it. Curved scissor works better because then you don't go high, you remain low. Yes, after deviating the flap on the medial surface, then we can use scissors to cut. Yes, without suturing, according to the case, is also valid. It's on as a gift. You can keep this splint over septum very well. I put a pack because I do a lot of turbinates. If it is only septum, you can put a splint. Rapid rhino is kept for 1 day or 2 days at the most. So majority of the times we remove it in 1 day. Sometimes we keep it for 2 days, depending on if there's a artery which is opened and all. Will this patient be on anti-allergic treatment in the post-op? Yes, for a month or so. We definitely give a nasal spray and a tablet, but not for a long term. After 6-7 months of septoplasty in first patient still having nasal crust. So this we have already taken. Quilting suture we have already taken. Excellent surgery. Thanks. Recorded video, yes, we'll put it on my YouTube. So you can get it from my YouTube page. We'll put it on the YouTube. Keystone area is their area where the septum joins the upper lateral cartilage. That's the keystone area. You could have seen it when the navigation was on. You let them finish this surgeon, then you can ask him to. Yeah, on the navigation you could see it very well. What is the solution you inject at the beginning before you use the flap? That's simple, 2% xylocaine with adrenaline, the standard which is made. Nowadays some surgeons are talking about cold saline infiltration. You can, but generally I infiltrate with the 2% xylocaine with adrenaline, the pre-made one. Yes, shaver, coblation, piezoelectric, luxury at its best, yes, because this is the best surgery you can do for the patient. Each purpose is different. All right. You always do the initial incision from the left. Yes, I always do it from the left because I'm used to it. But many times I have done it from the right if the septum was badly deviated on the right and I would believe that I have to take the incision on the right, I'll take it on the right. Can we do the adenoidectomy and septoplasty? Yes, absolutely. You always do adenoidectomy and septoplasty together. There's no point doing 2 surgeries on a patient. 100% not. Like this patient also, I had done adenoidectomy, septoplasty, turbinoplasty together. But I was conservative. 13, 14, 12, 13 years back, I was conservative. As everybody is saying that, no, a young person, you should be conservative. Your patient lands up with another surgery. So do a good surgery the first time. So thank you very much, all of you, for joining, and we'll join with you once again after a short while for another surgery, maybe a navigation guided surgery. Thank you very much. Good day.